Welcome back to Module 2 of the National Adoption Competency Mental Health Training. This is Lesson 4, Issues in Diagnosis and Treatment of Adopted Children's Mental Health Needs. At the end of this lesson, you'll be able to identify and describe the core mental health issues that are addressed in adoption-competent clinical interventions with children, youth, and their adoptive and guardianship families. Recognize limitations of current diagnostic assessment and medication practices commonly used with children and youth with foster and/or institutional care experiences. Identify and describe strategies for effective collaboration with child welfare and other professionals that promotes information sharing, appropriate treatment planning and intervention, and parental involvement in the therapeutic process. To begin, please click on the Start Course button located on the lower right portion of the screen. In previous lessons, we have discussed the increased likelihood that adoptees will access mental health services at a higher rate than their non-adopted peers. Based on several national longitudinal studies, we can conclude the following. Click on each number to hear more. With most of these children and youth, it is difficult to isolate only one issue to work on, or one diagnosis that captures the breadth of their mental health challenges, including adoption issues such as loss and identity. When this is the case, conventional mental health assessments, diagnoses, treatments, and psychotropic medications may not address some underlying causes of these challenging behaviors, and may in fact be harmful, delaying targeted and effective treatment of important issues. Children and youth with multiple risk factors often struggle with a range of challenging emotions, behaviors, and developmental deficits that frequently result in a string of diagnoses resembling alphabet soup. Conduct disorder, CD. Oppositional defiant disorder, ODD. Reactive attachment disorder, RAD. Attention deficit hyperactivity disorder, ADHD. Intellectual disabilities, IDD. Post-traumatic stress disorder, PTSD, depressive disorders including disruptive mood dysregulation disorder, DMDD, neurobehavioral disorder associated with prenatal alcohol exposure, NDPAE, and others. A meta-analysis of 85 studies on psychiatric disorders in adoptees and non-adoptees found that the risk of being diagnosed with a psychiatric disorder is significantly higher for adoptees. This elevated risk is greatest for conduct disorder and oppositional defiant disorder. Two other diagnoses that have risk ratios above 2.5 among adoptees are ADHD and psychoses. In the video of Zoe's story, we witnessed the impact of many risk factors. Zoe likely experienced prenatal exposure to elevated maternal stress and early interpersonal trauma from inadequate nurture, exposure to violence and physical abuse, disturbed and disrupted attachment relationships, traumatic grief, and other adversities. One of the most positive relationships in her life was with her baby brother, and separation from him withdrew a primary protective factor in her life. What diagnoses do you think might be given to Zoe? Please check any of the following that you think might be given: CD, ODD, ADHD, PTSD, depression, RAD, PDD, persistent complex grief. Looking through a trauma lens, how might your diagnoses change? As discussed in a previous lesson, children and youth from compromised beginnings will often demonstrate negative behaviors or survival coping strategies that reflect underlying emotional struggles. Let's look at some of these in more detail. Click on each section to learn more. Children and youth in foster care and adoptees have an elevated risk for neurodevelopmental disorders, particularly prenatal alcohol exposure. There are other toxic substances that also may cause impairments, but alcohol is the most common and the most developmentally devastating. The lifelong neurodevelopmental disability, which is labeled NDPAE, neurobehavioral disorder associated with prenatal alcohol exposure, in the DSM-5, was previously known as fetal alcohol spectrum disorder. Children and youth affected by prenatal alcohol exposure demonstrate some of the same symptoms as those with other developmental disorders, But there is no other medical or genetic condition that explains their symptoms, and there is more than minimal exposure to alcohol during prenatal development. There are 4 primary domains that can be impaired by prenatal alcohol exposure. Neurocognitive functioning, impairment in one or more of the following: IQ below 70, executive functioning, learning, memory, or visual spatial abilities. A child with FASD has trouble with remembering, understanding, and following directions. Sensory and motor functioning, deficits in sensory processing, delays in gross and fine motor development, problems with coordination and balance. Emotional regulation, controlling emotions and impulsivity. Social communication, difficulty understanding others or communicating with them. Difficulty reading social cues or social immaturity. All of these impairments result in problems in daily life skills. The impact of alcohol exposure during pregnancy is often not assessed, which greatly impacts clinical outcomes. Ira Chasnoff and his colleagues at a specialized mental health clinic analyzed the comprehensive, multidisciplinary diagnostic evaluations of 547 foster and adopted children who were randomly selected from over 3,000 who had been patients at the clinic. They found that 29% met the criteria for a diagnosis within the fetal alcohol spectrum. In this group, 80% had never been diagnosed as affected by prenatal alcohol exposure prior to their referral. Other children had received this diagnosis but did not meet the criteria. An in-depth protocol for treatment of these children, developed by SAMHSA, is in the resources, as well as the link to SAMHSA's website on prenatal substance exposure. It contains a variety of resources related to a range of substances, including opioids. One problem frequently also found among children experiencing institutionalization and deprivation or neglect is sensory processing disorder, or SPD. This is a condition in which the brain cannot analyze, organize, and integrate sensory messages efficiently. Click each letter to learn more. Many adoptees and children in guardianship experience prenatal and early life conditions that predispose them to chronic health problems, such as asthma, or a special need, such as traumatic brain injury or deafness. These challenges frequently increase economic, parenting, and social-emotional stresses for them and their families. The National Survey of Adoptive Parents reports that 26% of adopted children have moderate or severe health difficulties, and many have more than one health problem. Attachment challenges in both children and parents may pose risks for adjustment. Many children experiencing adverse early lives have disturbed attachment patterns. One study found that when an adoptive mother perceives a lack of attachment by the child, there is an 8-fold increase in adoption disruption. Adopted children may have many attachment challenges that do not fit either reactive attachment disorder, RAD, or disinhibited social engagement disorder, DSED, diagnosis. Therapists in a clinical post-adoption counseling program rated separation and attachment conflicts as underlying emotional issues in 3/4 of adopted children served. While these issues may not fit a diagnosis, they are central to addressing the child's challenges. Click on each number to hear some of these issues. Let's consider this case example. Click on each photo to hear the case. Evie has experienced significant losses. If you're looking at her circumstances through the lens of adoption, what are some strategies you can put in place? Many trauma and child welfare scholars have recognized the limitations of current diagnostic and treatment approaches to adequately address the complex range of challenges present in children and youth who have experienced multiple interpersonal traumas, defined as complex trauma. A new diagnostic category, complex PTSD, was added to the 11th International Classification of Diseases published by the World Health Organization. Complex PTSD expands the core PTSD symptoms to include dysregulation in 3 domains: emotion processing, self-organization, and relational functioning. Links to articles in the resources section delineate differences between PTSD and complex PTSD and their implications for treatment. Experts are also proposing a new classification, developmental trauma disorder. This characterizes children who have been exposed to multiple or chronic interpersonal traumas, usually in a caregiving relationship. This was not included in the DSM-5, but research is continuing to make the case for its inclusion in the future, and these issues will be examined further in the module on trauma. Close to 1/4 of children in foster care are 0 to 3 years of age. Infant mental health is a very important specialized field with modes of treatment that differ from that of older children. Click on each photo to hear about infant mental health. Let's turn now to a discussion of the use of medication in the mental health treatment of adoptees. In addition to limitations in assessment and diagnosis of children's mental health issues, another concern today for children in foster, adoptive, or guardianship families is the overutilization of psychotropic medication. Let's watch one more clip from Zoe's story related to her mental health treatment. Zoe is again separated from her brother, Benaiah, after having been reunited for a time in the same foster home. She is deeply affected by this and lashes out at those around her, particularly her foster mother. When she is taken for mental health treatment, the first strategy tried is medication.
Where's Kyra?
Hey, she had to leave early.
Oh. Benaiah! 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 Benaiah!
Zoe.
Benaiah!
Zoe, wait. Zoe. No, listen. Zoe, it happened so quickly they wouldn't let me tell you.
When I finally come close, it starts all over again.
She may have some negative side effects to it, but this will help with moments of uncontrollable anger. I really believe this will make life easier.
Zoe doesn't need meds. She needs more therapy. She needs more interaction with her mom.
You see what I do, but forget why.
You'll still get a chance to see him. Hopefully twice a month, maybe even more. I've already set up a play date for this weekend.
Why do they think they can just have him? They aren't his parents.
If it doesn't work, we can always up the dosage or add a second medicine to it to help you feel a little less sad or angry.
But why wouldn't you?
You forget what I've heard. You forget my pain.
There are times when medication is indicated and can be beneficial. In this situation, why might medication be contraindicated? A research brief in your resources handout, Psychotropic Medication Use by Children in Child Welfare, explores the use of psychotropic medication by children and youth in foster and congregate care. Click each image to learn some concerns that have been raised by this study and the federal government related to possible inappropriate use of psychotropic medications. According to the National Center for Health Statistics, 7.5% of U.S. children ages 6 to 17 take medication for emotional or behavioral difficulties. An Illinois study assessing the needs of close to 2,000 adopted children found that parents of all types of adopted children reported a high rate of psychotropic medication usage. 28% for private domestic infant adoptees, 29% for those adopted from another country, and 31% for those adopted from the child welfare system. In addition, research findings have raised other concerns, such as the fact that nearly 40% of foster and adoptive parents do not receive information about the purpose or side effects of psychotropic medications, and prescribers not monitoring important side effects in their oversight of this treatment. During your assessment, include questions for youth and their parents regarding current medications prescribed and their positive and/or negative side effects. Help parents find knowledgeable psychiatrists and pediatricians who work with this population for initial assessments or reassessments of youth. As a mental health professional, you can benefit from knowledge about a broad range of treatment approaches that address the mental health needs of the children, youth, and families with whom you work. Please review the resource on your screen, Evidence-Based and Evidence-Informed Treatment Models Most Commonly Used with Foster and Adopted Children. A PDF version can also be downloaded from the Resources tab. Please check out the models you are interested in by clicking on their associated websites. During this course, we will explore a few models in more depth, particularly those that have been created for children and youth experiencing complex trauma. Our goal is not to train you in specific practice models, but to help you learn more about some models that are tailored to the needs of this population. You can also review this resource, Ancillary Interventions for Working with Foster and Adopted Children and Youth, available for download in the Resources tab. This lesson provided a foundation for understanding a range of diagnosis and treatment issues, as well as interventions to address the mental health needs of children and youth. Click the Open tab to open the journal. Consider children you work with who have an IEP or 504 plan. What additional information do you need to understand the child's challenges? How might you view the information differently when viewed through the adoption lens and based on what you learned about diagnosis and medication use? Congratulations! You've now completed Lesson 5 of Module 2. Module 3 will focus on attachment, child development, and mental health.